So, as I told you before, I will tell you the clinical history of the patient, some details about his examination, his vitals, and if necessary, some lab results. And afterwards, I'll show you some video sequences of the ultrasound examination, and then you'll tell me the diagnosis. So first of all, imagine you're working in the emergency department of your hospital, and then there is this 34-year-old male. He's pretty tall, he's slender, and he's walking in. But he says, I'm pretty dyspnoic, I get a sharp pain every time I inspire. So you're not pretty concerned about the patient, his vitals are totally fine, but nevertheless you decide to do some auscultation and percussion. And after doing the auscultation and doing the percussion, you then decide to place the linear transducer on his pleural lines because you suspect one specific pathology and you want to verify this pathology, and that's what we see. I think after the talk of Dr. Brosen yesterday, everybody knows the answer, but which sonographic finding did we see in the previous clip? Was it A, C lines, was it B, B lines, C, the lung point, or D, the mirror image artifact? Who votes for A? Please raise your arm. B, C, and D? Of course, it's the lung point, but which pathology is the lung point highly specific of? Is it A, pneumothorax, B, pleuritis, C, a rib fracture, or D, pleurodesis? Who's for A? B, C, and D? Okay, of course. I think we could stop right now. Everybody knows everything, so we could stop now. I'm going to talk a little about the pneumothorax. So in this case, we are clearly seeing the lung point. So at one part of the, in one part of the picture, we were seeing a sliding lung sign. And on the other hand, there was no sliding between the visceral and parietal pleura. But why is that? In case of a pneumothorax, the visceral and the parietal pleura start to separate, so there will be air between those two layers and there will be no lung sliding anymore. And the lung point is exactly that point where the sliding pleural lines meet the non-sliding pleural lines. And that is 100% specific for a pneumothorax. What does it mean? It means if I see a lung point in scanning a patient, I know the patient has a pneumothorax. But if I see no lung sliding and I don't see the lung point, I cannot say that the patient has a pneumothorax if I don't know his history. So if I see arms marching or lung sliding, or if I take the M mode and I see the seashore sign, I can exclude a pneumothorax at this specific region. But if I see a barcode sign or just the absence of lung sliding, I cannot say that this patient has a pneumothorax without knowing his history. Just imagine this tall young man walking into the emergency medicine department again and saying, I have this right side sharp pain for about 4 hours, it's worse with inspiration. And once again you think of a pneumothorax. But then you decide to talk to him a little further, and then he tells you, well, I've had recurrent pneumothoraxes, and then they did a pleurodesis. In that case, you cannot say if the patient has a new pneumothorax or if it's just a result of a pleurodesis. That's why it's always important to take the clinical history beforehand. There is another artifact that might rule out a pneumothorax. Is it A, the A lines, B, the B lines, is it reverberations, or is it acoustic shadowing? Who is for A? B? C? There is nobody raising his arms, so who's for D? I think 10 people raised their arms. So once again, who's for A? B? C? And D? Okay, most of you polled for B, that's correct. So A lines and reverberations is actually the same, and it can occur in a normal lung as well as in a pneumothorax. And B lines can only occur if there is no pneumothorax. So if we watch this video oh, there is no video sequence. If we just look at this picture, we can see some vertical lines arising from the pleura. These are B lines, and they can only arise if there is no pneumothorax. A lines, on the other hand, can also arise if there is a pneumothorax, so they will not exclude the pathology. What are my take-home messages in that case? If there is a patient and you suspect a pneumothorax, the patient should lie in a supine position, and you might want to check multiple areas of the thoracic cavity, because you can only exclude the pneumothorax at the specific region you are actually scanning at the moment. So if you suspect a minor pneumothorax, you might want to check all regions of the thoracic cavity. In case you want to scan the pleural lines, you'd better go for the linear array. And if there is a patient who had a serious trauma, for example, and you just want to take an e-fast or a fast scan, you can just scan the second to fourth intercostal space perpendicular to the ribs, because we only want to rule out major pneumothoraces. So we have talked about our first patient, and we will now encounter our second patient, but it's getting more dramatic. So the ambulance and the paramedics actually bring you a 65-year-old female. She is severely dyspnoic, and she cannot really give you any more clinical history because she says, "I fear I'll die," and she's extremely agitated. So she sits in an upright position, she's totally sweaty, she's pale, and she uses her accessory muscles. So you check her vitals, and her blood pressure, her pulse, and her respiratory rate is extremely high, whereas her oxygen saturation is relatively low. And the paramedics tell you that they have already given her some Atrovent, for example, but it did not really work out. Her oxygen saturation still is really, really low. And then you decide to do some auscultation, because you don't really know, is the pathology from the lungs or does it arise from the heart? So you do some auscultation, and that's what you hear. So by taking the clinical history and by doing a thorough examination of the patient, you already have some diagnoses in mind. But you can already exclude some diagnoses as well, and that's what we are going to do at the moment. So can we exclude acute right heart failure, cardiac asthma? Can we exclude congestive heart failure or an exacerbated chronic obstructive pulmonary disease? Who votes for A? Who B? C? And D. Okay, the only thing we can actually exclude is A. Nobody voted for A. That's quite interesting. So the patient actually complains about severe dyspnea and wheezing. And mostly people with congestive heart failure would have some crackles in auscultation. However, in 1/3 of cases, they will present with wheezing. So this is possible as well. Cardiac asthma just means it's a heart failure where you have pulmonary symptoms that are the major symptoms. Exacerbated chronic obstructive pulmonary disease seems likely in this case. And patients with acute right heart failure, they'll present with swollen limbs, with swollen eyelids and ascites, but she won't probably have wheezing. So if we want to evaluate patients who present with dyspnea, we might want to take multiple views so we can assess the lungs and the heart. So first of all, we can take the peristernal long axis. We can take the peristernal short axis, the substernal view, the apical four-chamber view. We can obtain multiple lung views and the inferior vena cava view. And I'm now going to show you some video sequences of the ultrasound examination. And for all of you who have not scanned a heart yet, I'm going to explain you the anatomy, and you try to assess the function of the heart as well as the function of the lungs, please. So in the first video, we are seeing the left ventricle, right there. We are seeing the right ventricle. We were seeing the left atrium and the aortic bulb. Once again. We will now move on to the peristernal short axis. where we see the left concentric shaped ventricle and a little small part of the right ventricle. We move on to the lung, and if you scan the lungs, it will look the same throughout all parts of the lungs. And then we scan the inferior vena cava and its drainage in the right atrium. So by obtaining all those ultrasound views, I'm sure you can already tell me what the problem of the patient is. So what's your diagnosis? Is it myocardial infarction? Is it acute left heart failure, congestive heart failure, or is it an exacerbated chronic obstructive pulmonary disease? Who votes for A? B? C? And D? Okay, so B and C, it's actually acute congestive heart failure, not only left heart failure. I'll explain you why. So in the first section, we are actually seeing the peristernal long axis, and we see a massively dilated left ventricle, and you also see the bowing into the right ventricle. And you might also notice that the contractility of the left ventricle is really relatively low. That's what you see in the peristernal short axis as well. Just see that the contractility, once again, is really, really low. And if we watch the lung, we can see B lines all over, suggesting an interstitial edema. And last but not least, we watch the inferior vena cava, and we see that it's not at all collapsible, suggesting a right heart failure as well. So in this case, the patient suffers from congestive heart failure, and she got diuretics, and her symptoms disappeared thereafter. So what are my take-home messages in that case? If a patient is dyspnoic and you really don't know if it's pulmonary origin or if the problems arise from the heart, you'd best go for a cardiac sector array, and there are multiple views you can obtain so that you can make a diagnosis. But now we have seen enough patients who are dyspnoic. We go to the right upper quadrant pain. So imagine a middle-aged man. He has 3 days of paroxysmal right upper quadrant abdominal pain, and it goes along with nausea and vomiting. You do a clinical examination of the patient, but you don't notice anything. But if you think on the history, it sounds kind of biliary origin, so you decide to actually scan the gallbladder and look if there are any gallstones or if there is a cholecystitis. And that's what you see. So what's the problem of this patient? Is it a cholelithiasis, a cholecystitis second to cholelithiasis? Is it a hydrops, or is there no pathology at all? So who votes for A? C? And D? So there are actually some people who voted for D. That's perfect. So there is no pathology at all. Of course, there is some acoustic shadowing, but if you look closely, it does not originate from the gallbladder, but rather from a structure that is dorsal to the gallbladder. So if you scan the gallbladder, you might want to make sure that you know there is duodenum next to the gallbladder, or usually dorsal to the gallbladder. And in that case, that is a shadow that arises from the bowel gas. So sometimes it's pretty tricky to actually differentiate bowel gas from stones, but you might want to keep in mind that stones usually generate a clean shadow, whereas bowel usually generate a dirty shadow. And you might want to notice that this one arises dorsally to the gallbladder, and this one arises directly from the gallbladder. So what are my take-home messages in that case? If a patient complains about biliary symptoms, he has right upper quadrant, a pathology of the gallbladder is likely, and you might want to take the abdominal array or the curvilinear array and place it in mid-clavicular line, intercostally or subcostally. We now move on to a diabetic patient. She is 52 years old. She has one history of malaise, nausea, vomiting, bilateral flank pain, and she has some fever and dysuria. At the moment of presentation, she presents with 40.1 degrees Celsius fever and a respiratory rate of 16, and her blood pressure is relatively low. Her oxygen saturation is fine, and in clinical examination you notice flank pain bilaterally and some sort of abdominal distension. So you decide to actually look for the flanks, and that's what we see. And on the right-hand side, we see the foreleg. So what is the most likely diagnosis in that case? Is it ascites? Is it an uncomplicated pyelonephritis? Is it a perirenal abscess? Or is it an hydronephrosis? Who is for A? B? C? D? Okay. It's actually a perirenal abscess. So the patient clearly presents with symptoms of pyelonephritis. So she has flank pain, she has fever, she has dysuria, and she's a diabetic. So that clearly makes us the diagnosis of a pyelonephritis. If we're doing a scan of the left and right kidneys, we're actually seeing that the kidneys, they are kind of edematous. They are swollen, the kidney is enlarged, but the problem usually isn't the pyelonephritis in that case, but it's rather this structure over there. So it's kind of hypoechoic, and there are some hyperechoic pieces in it, and this is usually an abscess, and that's second to a pyelonephritis. So in this case, the patient has 2 perirenal abscesses. What are my take-home messages in that case? So if a patient complains about flank pain, you might want to make sure to check the right and left flank. And you also, once again, you want to scan the regions around the affected organ. So it might not be enough to only scan the kidneys, but you should also check the perirenal space. In case we'd only checked the kidneys, we might have missed the perirenal abscesses. And now we move to one last case. It's actually lower abdominal pain, but it should be pretty straightforward. So there is the 64-year-old female. At first she had this periumbilical pain, but then for about 3 hours it's now in the right lower quadrant. Also there is some vomiting and nausea, and her leukocytes are elevated a bit. Her CRP is about 20, but you are pretty sure that this is an appendicitis, so you place your transducer in the right lower quadrant, and you see the following. So you actually see a massively dilated structure in there. It's pretty edematous. There is probably a feculate, or who knows, there arises some acoustic shadowing, there is some edema, and the mucosa is pretty swollen. So it should be a case that is pretty forward, but what's your diagnosis in that case? We can see once again, we can see the horizontal plane. So which pathology is it? Is it a cholecystitis, an appendicitis, a gastroenteritis, or is it an active ulcerative colitis? Who is for A? B? C? And D? I think most people took B, but it's actually not. It's a cholecystitis. Of course, I wanted to trick you because we're talking about right upper quadrant pain and not about low quadrant pain. But this patient actually presented with lower quadrant pain, and she had this periumbilical pain So you might think of an appendicitis. But in ultrasound, and I don't want to tell you any lies, so you see the massively dilated gallbladder. And so she presented with symptoms in the right lower quadrant instead of symptoms in the upper abdominal quadrant. So, of course, that's a very unlikely scenario. It happens sometimes, but not that often. But what you want to keep in mind is that if you place your transducer in the right lower quadrant and you are not quite sure which structure it actually is, you might want to follow the structure till its origin. So this is a massively dilated structure. It's huge. If this was an appendicitis, there would be perforation all over. So what the examiner did is he followed the structure till its origin. And as we are following, we actually know that this structure originates from the liver. And by following a structure till its origin, we know where the pathology arises and we know what the organ is. So in that case, that was a cholecystitis and not an appendicitis. As we're having a cholecystitis at the moment, we want to exclude an extrahepatic bile duct dilatation as well. And which view can be of use? Is it peristernal short axis? Is it the CPC, the right flank, or substernal four-chamber view? Who is for A? B? C? And D? Okay, that's perfect. Everybody knows the answer. It's B. So if you want to exclude extrahepatic bile dilatation, you might want to place your transabdominal array in the epigastrial area, and you want to rotate it to the right shoulder of the patient. You might want to use an abdominal array, and you want to scan the gallbladder as well as the bile ducts in the liver and the extrahepatic bile ducts. So in this case, we are looking for the double-barreled shotgun sign, which means that a dilated bile duct will result in two parallel anechoic structures that quite resemble the portal vein. So this is physiologic anatomy. We are really seeing the inferior vena cava. We are seeing the portal vein here, and we are seeing the small structure that is actually the hepatic duct. And then this structure here is the hepatic artery. In case of bile duct dilatation, we would see the following image. So this is actually an extreme bile duct dilatation, but we would see the inferior vena cava, the portal vein, and the bile duct with the stone. So we wouldn't usually see the stone, but we would see the dilatation. And that's it. If you scan a patient with cholecystitis or with cholelithiasis, please check the bile ducts as well. So I'm already done with my quiz, and now I'd like to introduce you to our team in the control room, which is up there. And we are having some people from our team sitting up there who enabled a great live stream throughout the last day. And now I'd like to introduce you to our Kamerakind, and I'll present you Esther.
Hello from the control room. As you can see, people are busy here, having much fun and enjoying the privacy. I'm getting over to Esther. She's our Kamerakind. She knows how to control the joystick. Can you show it to us? And by doing this, she has charge of all the cameras you see in the room. She can control them remotely. And what we want to do now is, we want to give you two of the 3D printed models. Kerstin shows. The 3D printer was one of our most busy Sono-For-You tutor, and he created those two beautiful models, and we want to give them to you. And how does it work? Esther will control the camera, and the camera will point to one of the audience members. And and this member will receive the prize.
Esther will be blindfolded, so she does not know where she puts the joystick.
Toby will now blindfold Esther, and the audience can also shout to her so that she can listen to you and move the camera in the right direction. So if she should be totally off, please give her instructions where to go. Okay, can we now see the camera picture on the screen in the front? Nice. And can we also see Esther on the screen on the side? No, that's not possible. Okay. Okay, Esther, are you ready? Okay, so give it a go. Slowly, just go slow. Start low, go slow. Ah, okay, stop it. Yeah. Okay, we have a second model available. There's a second chance. Go really slow, Esther.
Our fairy godmother.
Say stop, she will listen to you.
No, you have to go further. We won't give them to ourselves.
Another try, one more try.
So I think we got a winner. So you now made the first bite of today. We're having a 10 minutes break, I think. I'll ask you out, please, and have some coffee and some drinks, and afterwards we'll continue with the lecture on hypertension. Thank you very much.